Deep gluteal pain syndrome, technical description of the endoscopic approach and anatomical considerations. The purpose of this study is to present an original surgical technique for the treatment of deep gluteal pain syndrome that allows access to both the peritrochanteric and subgluteal spaces through modified endoscopic portals. Previous studies have shown good results with the resection of fibrovascular bands associated with anatomy of the piriformis muscle. Our recently published technique with medium-term results include resection of inflammatory processes in both compartments without routinely performing a piriformis stenotomy, allowing free excursion of the sciatic nerve with favorable functional outcomes and without recurrence. The location and the access of both endoscopic portals were performed in a previous cadaveric study, establishing anatomical landmarks to manage both spaces with a lower risk of complications. Deep gluteal pain syndrome is an underdiagnosed entity that is characterized by the presence of pain due to non-discogenic entrapment of the sciatic nerve, which can occur in any anatomical region of the gluteus, and whose etiology has been attributed to compression of the piriformis tendon. Several reports currently suggest that the fibrovascular bands are primarily responsible for the sciatic nerve entrapment. These structures are frequently associated with hypertrophic bursa in the lateral space and tibial tibial band. Hence, considering the anatomical continuity between these spaces, we believe it is necessary to perform the treatment in both. These fibrovascular structures in the posterior space are generally produced by extension of the inflammatory process from the lateral space. Moreover, these bands may appear because of trauma events in the presence of an extensive hematoma. We use two portals that allows access to the lateral space to address peritrochanteric pathology and the subgluteal space to release fibrovascular bands. We do not perform a piriformis stenotomy as we consider that the sciatic nerve entrapment is produced mainly by the fibrovascular bands, and this stenotomy puts the piriformis branch of the inferior gluteal artery at risk. The specific steps to performing this procedure consist of preparative planning with the identification of landmarks, positioning the patient and setup, the marcation of the portals, access to the lateral space performing the peritrochanteric bursectomy and partial gluteus maximus distal insertion tenotomy, access into the posterior space, fibrovascular adhesion release, excursion evaluation of the sciatic nerve, evacuation of the remaining fluid, and closure.